Welcome to Medication Talk, an official podcast of TRC Healthcare, home of pharmacist letter, prescriber insights, and the most trusted clinical resources. On this special bonus episode, we're revisiting our Notable New Meds of 2025 webinar to cover two medications we didn't have time to include in the main podcast, both of which are new antibiotics: Gepotidacin, Blujepa, for uncomplicated urinary tract infections, and Aztreonam, Avibactam, Emblaveo, for complicated intra-abdominal infections. We'll walk through where these drugs fit in therapy, key safety and interaction concerns, and practical tips so you feel more prepared when you see Blujepa or Emblaveo ordered or dispensed in your practice. And just so you know, this bonus episode does not include continuing education credit. We still wanted to share these two additional 2025 approvals because they offer timely, real-world options for challenging infections and can help you feel more confident when you see Blujepa or Emblaveo on an order, a profile, or a prior auth request. You'll hear from our regular hosts, two of our pharmacist editors on our team at TRC Healthcare, Associate Editor Sarah Clockers and Assistant Editor Stephen Small. Now, let's take a closer look at these two new antibiotics.
And now let's move to some new antibiotics from 2025, starting with Gepotidacin or Blujepa for uncomplicated urinary tract infections. Let's first talk about what makes a urinary tract infection or UTI complicated versus uncomplicated, since Gepotidacin can only be used for uncomplicated cases. Uncomplicated UTIs are those that only affect the bladder. They don't involve other organs, and patients cannot have a fever. So, pretty simple. UTIs are considered complicated, though, if they spread from the bladder, such as to the kidney, known as pyelonephritis, or into the blood, known as bacteremia. And if a patient has a fever, even with a bladder infection, that's also considered complicated. And patients with prostate infections or even urinary catheter infections also fall into this group. So Gepotidacin cannot be used for those patients. Generally, complicated UTIs need more aggressive therapy, including possibly IV antibiotics in the hospital. Now, UTIs are commonly caused by gram-negative bacteria, with E. coli being the most common. And for uncomplicated UTIs, patients typically require 3 to 14 days of antibiotics, which usually depends on several factors, such as the antibiotic used. And we currently have several antibiotics for uncomplicated UTIs. You've likely seen prescriptions for antibiotics such as nitrofurantoin or cephalexin, and even quinolones such as levofloxacin. But we do know that antibiotic resistance poses an increasing threat to infection treatment, making these options unusable for some patients. Plus, we know patients may have adverse effects or even allergies to certain antibiotics, creating a need for alternatives. Now, Gepotidacin has been approved as an antibiotic, specifically for women 12 years and up who are at least 40 kilograms who have an uncomplicated UTI. And Gepotidacin is considered a type 2 topoisomerase inhibitor. Let's look at that mechanism in more detail. So, topoisomerase enzymes are used by bacteria to help unwind DNA strands, opening them up so they can be used to make proteins. Specifically, it helps take out kinks by temporarily breaking apart the DNA strand. And once proteins are made, topoisomerase then joins the DNA back together, zips it up, and goes off to do its job somewhere else in the DNA strand. Now, Gepotidacin stops topoisomerase from leaving the DNA strand, so the DNA stays broken, making the bacteria unable to make vital proteins, and then the bacteria die. And this is very similar to quinolone antibiotics, which also inhibit topoisomerase enzymes, but Gepotidacin binds to a different site on that enzyme. So bacteria can have resistance to quinolones, but Gepotidacin's different site may offer another route to kill those resistant bacteria. In terms of dosing, Gepotidacin comes as 750 milligram oral tablets, and patients must take 1,500 milligrams or 2 tablets twice a day for 5 days. The manufacturer specifies doses should ideally be taken roughly 12 hours apart, such as 8 a.m. and 8 p.m., based on how it was given in studies. And it's important to take it with food to help decrease GI side effects that we'll talk about soon. And keep in mind that it's cleared by the liver and kidneys, so we should avoid gepotidacin in patients with severe dysfunction of either of these organs. Jumping back to side effects here, some of gepotidacin's adverse effects are similar to what we'll see with quinolones and even antibiotics in general. Things like joint pain and QT still prolongation are things we look out for quinolones, and nausea and vomiting we see with many meds. But another interesting aspect of gepotidacin is that it has cholinergic activity. It stimulates things like salivation and sweating, and even GI motility, causing abdominal pain and diarrhea. Now, let's talk about this cholinergic activity a little bit more because it also plays a role in drug interactions. These cholinergic side effects likely occur because gepotidacin has been shown to inhibit acetylcholinesterase. This enzyme breaks down acetylcholine, a neurotransmitter that stimulates receptors that make us salivate, sweat, etc. And inhibiting that enzyme increases these bodily functions because levels of acetylcholine go up. In terms of drug interactions, this means that it can add to the effect of other cholinesterase inhibitors, meds such as donepezil, used for Alzheimer's disease. It can also increase the muscle relaxant effect of succinylcholine, an injectable used in the hospital for intubating patients. It can also counteract the effect of anticholinergic meds as well. There's lots of examples in this class. So you may recognize meds like hyoscyamine for irritable bowel syndrome or oxybutynin for overactive bladder. Also avoid this antibiotic with CYP3A4 inhibitors such as itraconazole we were talking about before. These inhibitors can actually increase the level of gepotidacin in the body. And on the flip side, avoid using it with CYP3A4 inducers as well, meds such as rifampin. These can increase the metabolism of gepotidacin, which can cut levels in half. And gepotidacin can also prolong the QT interval or timing within certain sections of the heart rhythm cycle. We also see this with quinolone antibiotics. And QT prolongation is important to think about since it can lead to possible arrhythmias, which can potentially be fatal in some cases. And it's important to avoid gepotidacin in patients with existing QT prolongation, and also to weigh the potential risks in patients who are taking other QT prolonging meds. This includes certain antiarrhythmics like amiodarone, antipsychotics such as haloperidol, and methadone. Based on all this, don't expect to routinely use gepotidacin for UTIs. Instead, expect to reserve it for patients with little to no other antibiotic options, whether that's due to prior treatment failure or resistance. And it can be used for E. coli strains that are quinolone resistant. Since this med is approved for women, including teens, it's important to point out here we don't have pregnancy or lactation safety evidence, and it's reasonable to recommend contraception in those cases. And with this medication, it's also expensive, almost $2,000 for a 5-day course. If dispensing gepotidacin, it's important to make sure to emphasize that 12-hour interval for patients between doses. And it's a good idea for patients to set timers for themselves to ensure they follow this approximate spacing. And it's important to highlight taking it with food, since GI intolerance can lead to poor adherence. We want patients to get the best out of their therapy. And in the hospital, if you're using this medication, it's too soon to say how gepotidacin susceptibilities will be reported by labs. So don't jump to extrapolating quinolone sensitivity data to this med, even though they're related. For example, it may be effective for quinolone resistant E. coli. And it's a good idea to consult your infectious diseases colleagues if you have questions. Now, regardless of whether you're in a hospital or a community pharmacy, watch for drug interactions with this med. As we saw before, there are many potential interactions. Ensure EHR warning pop ups are updated to include gepotidacin to help you spot those possible interactions. And keep in mind, gepotidacin tablets come in a 20 count bottle, which matches up with the 5-day recommended duration. And this is a great chance to mention our urinary tract infections chart online. Use it as a helpful resource for comparing uncomplicated and complicated UTIs, along with appropriate antibiotic options to consider.
So, Steve, we are getting an audience question about gepotidacin. Can you use gepotidacin if patients have an allergy to quinolones, such as levofloxacin?
That's a great thought since both meds inhibit the same bacterial enzymes we talked about. But despite that similarity, there's still different chemical classes at the end of the day. So the risk of a cross reaction here is low. But it's still important to advise patients to watch for hypersensitivity symptoms, things like hives, swelling the lips or tongue, things like that.
Excellent. Thank you. And I have one more for you. Is Blujepa also approved for gonorrhea?
Yes, Gepotidacin is also approved for uncomplicated urogenital gonorrhea in patients specifically 12 years and older who weigh at least 45 kilos or 99 pounds. And for now, really don't expect to see this much, as it's likely to be safe for patients who really can't take other options that we know have a longer track record of safety and efficacy. And on the topic of gonorrhea, another new med, Nuzolvence or zoliflodacin, was also approved for this indication in patients 12 years and older. So stay tuned for more when this becomes available. And keeping with the antibiotic theme, let's move to a new IV antibiotic for all of our hospital colleagues in the audience. We'll talk about Aztreonam Avibactam or Emblaveo for complicated intra-abdominal infections. Similar to UTIs, abdominal infections can also be uncomplicated or complicated. Uncomplicated cases are infections confined to the inside of a GI organ. A good example here, a classic one, is unruptured appendicitis. Sometimes these patients don't need surgery and just require antibiotics, but cases can become complicated if they're allowed time to spread, such as if appendicitis ruptures. Complicated cases can be serious. Plus, these patients typically need surgery to control the infection, along with using broad spectrum antibiotics. They have a higher risk of bacterial resistance, making outcomes potentially worse. Diving deeper into resistance risks here, some bacteria can make beta lactamase enzymes. These enzymes chew up and deactivate beta lactam antibiotics, which include classes such as penicillins and cephalosporins, including cephalexin. In fact, there are four classes of different beta lactamase enzymes, all with different ways that they work, and bacteria that make them. A concerning one right now is class B or metallo beta lactamases, abbreviated as MBLs. These specifically can break down carbapenem, such as meropenem or imipenem, which are some of our go to antibiotics for very serious infections, or if patients have resistance to typical options. And this MBL resistance is worrisome because it leaves us with few options to otherwise help patients if they have it. This resistance with MBL is interesting because it plays into the backstory about why Aztreonam avibactam was developed. Some hospitals have been using Aztreonam with the combo drug ceftazidime avibactam or Avicaz to treat multi-drug resistant bacteria, especially MBLs. This is because Aztreonam and Avibactam work together against all four classes of beta lactamases. Avibactam inhibits classes A, C, and some D lactamases, while Aztreonam has a structure that isn't affected from class Bs, so it's in a way shielded from that. And you may be wondering, what about ceftazidime here? Well, it sort of frankly just sits on the sidelines since Aztreonam and Avibactam pretty much have it covered. And the question then became, why can't Aztreonam and Avibactam just be combined together in that case? And that is how we now have Aztreonam Avibactam. It's specifically for complicated intra-abdominal infections in adults when they have no other options due to resistance, adverse effects, or other factors. And it must be combined with metronidazole in these cases to cover anaerobic bacteria in the gut, or Bacteroides, as a common example, which can occur in intra-abdominal infections. You may notice that the labeling for Emblaveo points out that approval for this indication is based on limited clinical safety and efficacy data. Now, the study evidence we have is pretty minimal for these meds as a combined single product. Instead, in this case, the FDA mostly relied on data we have for Avibactam alone and Aztreonam alone to really justify this approval. In terms of how it works, we said earlier that some bacteria may have beta lactamase enzymes that can chew up Aztreonam, making it ineffective. But thankfully, Avibactam can bind to and inhibit these enzymes, preventing Aztreonam from breaking down. So you can think of Avibactam as being Aztreonam's bodyguard in a way, protecting it from being damaged by these beta lactamase enzymes. And this protection allows Aztreonam to then bind to penicillin binding proteins in bacteria, which then stops bacterial cell wall production, which eventually then kills bacteria. Now, this medication is only available IV and it comes in 2-gram vials. Keep in mind that each vial has 1.5 grams of Aztreonam along with zero point 0.5 grams of Avibactam. And for patients with normal kidney function, so creatinine clearance above 50 mils per minute, It's recommended to give 2.67 grams as a loading dose, followed by 2 grams IV every 6 hours. Now, patients with poor kidney function need their doses adjusted. And this medication is infused over 3 hours. That's longer than we typically see for most antibiotics. And what's also interesting is that each dose can be diluted in at least 50 mLs or up to a max of 250 mLs of diluent. Now, this can be a bag of normal saline, dextrose 5%, or even lactated ringers. But at 250 mLs per dose, this means that a patient could get an extra 1 liter of fluid per day from this med alone. Now, that could be a lot of fluid, especially for a seriously ill patient. Some other unique side effects to think about are liver injury, anemia, and low potassium levels with this antibiotic. And in general, patients getting this medication in the hospital are likely ill enough that they'll be getting these labs checked regularly anyways. Now, similar to Gepotidacin, don't expect to commonly see this medication in practice. Where this antibiotic can come in handy is to treat MBL resistant infections in the hospital when we would otherwise turn to carbapenems like meropenem or imipenem. Now, some experts expect that Aztreonam Avibactam might be used off label outside of just intra-abdominal infections because of its unique niche. And it's more convenient than combining Aztreonam with ceftazidime plus Avibactam. But expect hospitals to likely have restrictions for using this antibiotic, if they even carry it at all. For example, they'll likely need approval from your infectious diseases consult service first before dispensing it for a patient. And keep in mind that this antibiotic is still not effective against some bacteria, including gram-positive bacteria, such as Staphylococcus. And like we said earlier, it is not effective against anaerobes, so it must be combined with metronidazole to give that coverage for intra-abdominal infections. And pharmacists can play a role ensuring that metronidazole is ordered with this med. They should also be prepared for compatibility questions. That 3-hour infusion time can really tie up an IV line. And since we don't have a lot of compatibility data yet, nurses will be calling for recommendations. So, for example, adjust med timing or recommend adding more IV sites to run Aztreonam Avibactam alone. Clarify beyond use dating in the admin instructions for nurses. This med should be refrigerated for up to 24 hours after prep, but after that, it's a bit unique. Bags can then be stored at room temp for a limited time, depending on their diluent. So, for example, a dose diluted in normal saline can be stored at room temp for up to 12 hours after being in the fridge for 24 hours. But that timing is different for, let's say, dextrose 5%. And this can be confusing. So, ideally, work with your IT colleagues to include automatic text in the order that explains this beyond use date info for nurses. Also, watch for pulmonary edema or other fluid overload symptoms if using those large diluent volumes we discussed. And when appropriate, advocate diluting this antibiotic in the smallest volume needed to really avoid this issue. And it's good stewardship to have stop times on any antibiotic orders to make sure they aren't used longer than needed. For this antibiotic, generally limit the duration to 5 to 14 days of therapy. For technicians, watch for possible confusion between Aztreonam Avibactam and ceftazidime Avibactam. They sound very similar, but they are not the same. Keep in mind that the Aztreonam version is refrigerated, whereas the ceftazidime vials are stored at room temp. Diluents can also be confusing here, as Aztreonam Avibactam must be reconstituted with sterile water and then mixed in normal saline, dextrose 5%, or lactated ringers. And the clock is ticking here. Once you reconstitute a vial with sterile water, you'll need to transfer that to the diluent bag within 1 hour. Don't let vials sit out in the IV room hood. And I'll admit, the loading dose for this med is a bit unique, 2.67 grams. So expect to use 2 vials for that dose, and you will have some drug left over. There's lots to know about this interesting antibiotic, so check out our Aztreonam Avibactam new drug info sheet online as a quick guide on dosing, preparation, and more.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, you can log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and access and print out additional materials on this topic, like charts and other quick reference tools. We've linked directly to a few relevant ones right in the show notes. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insight subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1026 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.